Hello everyone, my name is Dr. Sikandar and today we will discuss about the gold guidelines for COPD and this is 2023 edition. So this is the part 1 for a gold guideline for COPD. So what is the definition of COPD? So COPD is a heterogeneous disease. This is a heterogeneous disease which is characterized by the chronic respiratory symptoms which are dyspnea, cough, sputum production and exacerbations due to abnormalities of the airway, either of the airway. Those are like bronchitis or bronchiolitis and alveoli or alveoli. So it could be due to emphysema that causes persistent, often progressive airflow obstruction. So this is the COPD. So COPD is a heterogeneous disease which contains some chronic respiratory symptoms, involve airway and alveoli, and causes persistent, often progressively increasing airflow obstruction. So what are the causes and risk factor for COPD? COPD result from the gene environment interactions occurring over the time, occurring over the lifetime. So which is also known as genomics. Genomics means G for gene, E for environmental, T for time. So we also called it genomics. That can damage the. So this is like very important thing. We also call it genomics. So they are telling that can damage the lungs and or alter their normal development aging process. The main environmental exposure leading to COPD is, we already know, tobacco smoking and the inhalation of toxic particle and gases from the household and outdoor pollution. But other environmental and host factor including abnormal lung development and accelerated lung aging can also contribute. So main factor are like tobacco smoking and household and outdoor air pollution. And what are the most relevant genetic factor for COPD are like mutation of SERPINA1 gene, SERPINA1 gene that lead to alpha 1 antitrypsin deficiency. This is very very important. This is like most relevant gene. A number of other genetic factors can also contribute to this thing. So what are the diagnostic criteria for diagnosis of COPD? So they are telling in the appropriate clinical context, definition and causes and risk factor, and the presence of non-fully reversible airflow limitation means FeV1 by FVC should be less than zero point 0.7 post bronchodilation. Very very important. It should be post bronchodilation, not pre bronchodilation. And measured by spirometry confirm the diagnosis of COPD. They are telling in some individuals can have respiratory symptoms and structural lung disease could be there, and physiological abnormalities could be there without airflow obstruction. Then we will call it. So they are telling like symptoms could be present, but there is no airflow obstruction. Means FeV1 upon FVC post bronchodilator is either equal to or more than zero point 0.7, then we will call it as pre-COPD subjects. Very, very important. So, like, what is pre-COPD? Pre-COPD is like ratio of FEV1 upon FVC is normal and symptoms are there. Then we will call it as pre-COPD. And what is PRISM? There is another term known as PRISM, PRISM, which is preserved ratio impaired spirometry. Very very important. It means in these patients like ratio of FeV1 upon FVC is normal, but FeV1 individually is deranged. Then we will call it as prism. So they are telling both pre-COPD and prism are at risk for developing airflow obstruction over time, so they can develop COPD in future life. So these subject are we should take some preventive measurement in these patients. So what is the clinical presentation of COPD? Patients with COPD typically complain of, as we already know, dyspnea, activity limitation, cough, with or without sputum production, and may experience acute respiratory event characterized by increased respiratory symptoms called exacerbation could be there. Patient with COPD frequently harbor comorbid disease could be there. They are telling what are the new opportunities in this field of COPD. So they are telling COPD is common disease, it is preventable disease and treatable disease, but extensively it is underdiagnosed and misdiagnosed, which lead to patient not receiving any treatment and incorrect treatment. So appropriate and early diagnosis of COPD have a very significant public health impact. Very, very important. So, the realization that environmental factor other than tobacco can contribute to COPD, that it can start early in life and affect young individuals, and that there are precursor conditions like pre-COPD and PRISM, we have already discussed, open new windows of opportunity of its prevention and early diagnosis and prompt and appropriate therapeutic intervention we can take earlier in life. And now like they are talking about the diagnosis, so like we have discussed what is the like definition of COPD. So now we will discuss how we will diagnose it. So a diagnosis of COPD should be considered in any patient who has dyspnea, chronic cough or sputum production, and or history of exposure to risk factor of this disease. We have already discussed like tobacco smoking, environmental factors, like that. But forced spirometry that demonstrate the presence of post bronchodilator FEV1 upon FVC less than zero point 0.7 is mandatory, very, very important. So this criteria should be fulfilled. Compul it is very compulsory criteria. So yeah, they are telling this is mandatory. FEV1 upon FVC should be less than zero point 0.7, very, very important, and it should be post bronchodilator for the diagnosis of COPD. Next slide. So what are the clinical indicator for considering a diagnosis of COPD? Consider the diagnosis of COPD. If you are suspecting symptoms, there are symptoms of COPD, then we have to perform spirometry if any of these clinical indicators are present. So what are these clinical indicators? If dyspnea is there, so dyspnea should be progressively increasing over time, worse with exercise, and it should be persistent. Recurrent wheeze should be there. Chronic cough may be intermittent or unproductive. Recurrent lower respiratory tract infection, history of recurrent lower respiratory tract infection is there. History of any risk factor like tobacco, smoke from home, cooking or heat fuel, occupational dust, vapor, fume, gas, and other chemicals. Host factor like genetic factors are there. Developmental abnormalities, low birth weight is there. Prematurity, childhood respiratory infections history is there. Then we will go for further go for spirometry. So they will discuss about the symptoms of COPD. First, they are telling like chronic dyspnea is the most characteristic symptom of COPD. Very, very important. So what is the most characteristic symptom of COPD? Is chronic dyspnea. Cough with sputum production is present in up to 30% of the patient. These symptoms may vary from day to day and may precede the development of airflow obstruction by many years. Individuals, particularly those with COPD risk factors presenting with these symptoms, should be examined to search the underlying cause. Airflow obstruction may also be present without chronic dyspnea and cough or sputum production. It could be there. Although COPD is defined on the basis of airflow obstruction, in practice the decision to seek medical help is usually determined by the impact of symptom on the patient's functional status. Very, very important. So it is not like only airflow obstruction. We have to see like what is the impact of symptoms on the patient's functional status. A person may seek medical attention either because of chronic respiratory symptom or because of acute transient episode of exacerbated respiratory symptom. So in any case, we will go ahead for COPD. So they are telling like about the chronic cough. Chronic cough is often first symptom of COPD, and now they are telling uh, and is frequently discounted by the patient. as an expected consequence of smoking. Like patient used to think like it is because of smoking or environmental exposure. Initially the cough may be intermittent, but subsequently it may present every day or often throughout the day. Chronic cough in COPD may be productive or unproductive. In some cases, significant airflow obstruction may develop without the presence of cough. Other causes of chronic cough are listed in later. Syncope during cough in patients with severe COPD can occur due to rapid increase in intrathoracic pressure. Very, very important. He is discussing about two factors. First is syncope and second is rib fracture. So they are telling like syncope during cough in patient with severe COPD can occur due to rapidly increasing in intrathoracic pressure during prolonged attack of coughing. If patient is constantly coughing, then it can lead to increase in intrathoracic pressure, which will lead to decreased blood flow to brain and lead to syncope. And coughing spells may also cause rib fracture, which are sometimes asymptomatic. So, like coughing can cause rib fracture and syncope in the patient with COPD. Very, very important. And like chronic cough is the first symptom of COPD. We have to remember this thing also. Now we will come to sputum production. So COPD patient commonly raise small quantities of tenacious sputum with coughing. Regular production of sputum for 3 or more months for 2 consecutive years is the classical definition of chronic bronchitis, as we know. But this is somewhat arbitrary definition that does not reflect the entire range of sputum production that occurs in COPD. So it is not necessarily like sputum production will be there in COPD patients. So sputum production is often difficult to evaluate because patients may swallow the sputum rather than expectorate it, because it used to be a habit in these patients, a habit that is subject to significant culture or sex variation. Furthermore, sputum production can be intermittent with period of flare-up interspersed with period of remission. Patients producing large volume of sputum may have underlying bronchiectasis. The presence of purulent sputum reflect an increase in inflammatory mediators. So they are telling like there will be increase in inflammatory mediators also, and its development may identify the onset of bacterial exacerbations, though the association is relatively weak. Now they are talking about wheezing and chest tightness. Inspiratory or expiratory wheeze could be there, and chest tightness are the symptoms that may vary between days over course of single day or and they are telling like chest tightness often follow exertion and poorly localized and like is muscular in the nature and may arise from the isometric contraction of the intercostal muscles. So this chest tightness is due to isometric contraction of intercostal muscles. An absence of wheeze or chest tightness does not exclude the diagnosis of COPD. So like it is not necessary to be chest tightness to be present or wheeze should be present. So now they are telling like fatigue. Fatigue is the subject of feeling of tiredness or exhaust and is the most one of the most common and distressing symptoms which is experienced by the patients with COPD. So people with COPD describe their fatigue as a feeling of general tiredness or as a feeling of being drained of energy. Fatigue impact the patient's ability to perform daily activities and living and quality of life. Very, very important. So yeah, this is also an important symptom. Then comes other additional features. What are those? Weight loss could be there, muscle mass loss could be there, anorexia could be there, which are present in severe and very severe COPD cases. So we have to like differentiate it, like other cause could be there, like tuberculosis or lung cancer could be there. Because of these, anorexia, muscle mass loss, or weight loss could be there. Now they are telling like ankle swelling may indicate the presence of corpulent, already we know. Symptoms of depression and anxiety could be there. And all these things are associated with poor health status, increased risk of exacerbation and emergency hospital admission, and like they are treatable. So, what are the other cause of chronic cough? So they are telling like intrathoracic causes are asthma, lung cancer, tuberculosis, bronchiectasis, left heart failure, interstitial lung disease, cystic fibrosis, idiopathic cough could be there. And what are the extrathoracic causes? So these are chronic allergic rhinitis, post-nasal drip syndrome, upper airway cuff syndrome, gastroesophageal reflux, or because of side effect of medication like AC inhibitors. Then they are discussing about the differential diagnosis of COPD, as we already know, like asthma could be there. So what is the difference between asthma and COPD? So they are telling in asthma there will be variable airflow obstruction symptoms vary widely from day to day, and symptoms worse in night or early morning. Allergy, rhinitis, eczema history could be there. Often they are present in children, and family history of asthma will be there. Congestive heart failure could be there. So they are telling chest X-ray show dilated heart and pulmonary edema will be there. Pulmonary function test indicate the volume restriction and not airflow restriction. So only volume restriction will be there in congestive heart failure. In bronchiectasis, they are telling like large volume of purulent sputum will be there, and they are commonly associated with bacterial infection. And bronchial dilatation will be there in chest X-ray or HRCT. In tuberculosis can present in any age. It is not necessarily like tuberculosis will be there in adult, but COPD will be there in adult life. So tuberculosis can be present in any age group. Chest X-ray will show lung infiltrate already. Microbiological confirmation will be there, and high local prevalence of tuberculosis could be there. And they are telling obliterative bronchiolitis. It can occur in children's, seen after lung or bone marrow transplantation. It can be present. HRCT on expression, so hypodense area will be there. And diffuse pain bronchiolitis, predominantly seen in patients of Asian descent. Most patients are male or and non-smokers. Almost all have chronic sinusitis, and chest X-ray and HRCT shows diffuse small centrilobular nodular opicities and hyperinflammation. So like asthma, congestive heart failure, bronchiectasis, tuberculosis, obliterative bronchiolitis, diffuse pain bronchiolitis are differential diagnosis of COPD. Then they are discussing about like what history we have to take from the patient with COPD. So they are telling like patients exposure to risk factor history will be there, like smoking and environmental exposure like household or outdoor. Then past medical history will be there, including early life event like prematurity, low birth weight, maternal smoking during pregnancy, passive smoking during infancy, asthma, allergy, sinusitis, nasal polyp, respiratory infection in childhood, and HIV and tuberculosis. So this history could be there, past medical history. Family history could be there. Pattern of symptoms development, they are telling like COPD typically develop in adult life, and most patients are conscious of increased breathlessness. So this is progressive in nature. More frequently or prolonged winter cold will be there, and social restriction for a number of years before seeking medical help will be there. History of exacerbation could be there. History of previous hospitalization could be there. And they are telling like presence of comorbidities like heart disease, osteoporosis, musculoskeletal disorder, and anxiety. So these history we have to take. Impact of disease on patient's life we have to take, like patient is there in anxiety, depression or not, about his well-being, sexual activity, then missed work, economic impact and effect of family routines is there or not. Social and familiar support we have to ask for the patient, and like possibility of reducing risk factor, especially smoking cessation we have to ask. Then comes spirometry. So they are telling like spirometry, force spirometry is the most reproducible and objective measurement of airflow obstruction. It is non-invasive, reproducible, cheap, readily available test. They are telling good quality spirometric measurement is possible in any healthcare system. So the spirometric criteria for airflow obstruction selected by gold remains post bronchodilator ratio of FEV1 upon FVC less than 0.7. We have already discussed it a lot of times. This criteria is simple and independent of reference values because it relates to variable measured in the same individual and has been used in all clinical trials that form the evidence base from which treatment recommendations are drawn. It should be noted that use of fixed Fe1 upon FVC ratio less than 0.7 to define airflow obstruction may result in overdiagnosis of COPD in elderly patients and underdiagnosed in the young patient, especially in mild disease, compared to using a cutoff based on the lower limit of values. So we have to use like lower limit of normal value. So this is like much better to use lower limit of normal for that particular age group. Okay. Then comes what are the consideration in performing spirometry. So now they are telling. So what are the consideration? So yeah, they are telling that we have to prepare properly. Then they are telling in performance like what should be spirometry findings. So they are telling like the pause between inspiration and expiration should be less than 1 second. As we know, we used to tell patient during spirometry like to inhale and then exhale. So like gap between those inspiration and expiration should be less than 1 second. The recording should go on long enough for a volume plateau to be reached. As we already know, like this kind of plateau used to be there. So this like they are telling, so this volume should be enough. So it can take time of around 15 seconds also. Normally it used to be like 6 seconds, but they are telling it can take 15 seconds in severe disease. So we should go enough. We should like tell patient to continuously exhale or inhale, and they are telling like both FVC and FE1 should be the largest value obtained from any of three technically satisfactory curve, and FVC and FEV1 value in these three curves should not be more than 5%, should not vary for 5% or 150 ml, whichever is greater, we have to like use it. They are telling like these three findings should also be like almost similar, like they should not vary more than 5% or 150 ml in their values. So of these we have to take like greater value. So now they are telling about like the FeV1 upon FVC ratio should be taken from the technically acceptable curve with the largest sum of FeVC and FeV1. So like how we used to give bronchodilator in these patients. So they are telling like possible dosage protocol are like 100 microgram short acting, sorry, 400 microgram short acting beta agonist, 400 microgram short acting beta agonist we have to give, or like 160 microgram short acting anticholinergic, or combined dose. They are telling like FE1 should be measured 10 to 15 minutes after giving SABA, or 30 to 45 minutes after giving SAMA, or combination of both classes of drug. And they are telling like patients, or if patient is already on bronchodilator treatment, then there is no need to stop the treatment during spirometry. Very very important. So there is no need to withhold the treatment like we used to do it in asthma patients, but it is not necessary to do in COPD patients. And in evaluation we already know the presence of bronchodilator. Post bronchodilator FEV1 upon FVC ratio less than 0.7 confirm the presence of non fully reversible airflow obstruction, and this is COPD. So, like, what is the initial assessment? Once the diagnosis of COPD has been confirmed, in order to guide therapy, COPD assessment must focus on determining the following four fundamental aspects. First thing is what is the level of severity of airflow limitation, nature and magnitude of current symptoms, previous history of moderate or severe exacerbation is there or not, or presence and type of other disease is there. Like we have to check any other comorbidities there or not. Okay, guys, now we will discuss about the severity of airflow obstruction. So they are telling in the presence of FeV1 upon FVC ratio less than zero point 0.7, we will check like what is the grading of gold's grading. So this is like compulsory criteria. FEV1 upon FV should be less than zero point 0.7 in every patient. After that, we will go for gold 1, 2, 3, 4. So gold 1 is mild and it contain like FEV1 is equals to or more than 80% of the predicted. Gold 2 is moderate and like FeV1 is less than 80% to equals to or more than 50%. Then comes gold 3, which contains severe and it contains less than 50% to equals to or more than 30%. And then comes gold 4, it contains very severe patients, very severe, and like FeV1 is less than 30% of predicted. Then comes modified MRC dyspnea scale. So there are like five grades: MMRC grade 0, MMRC grade 1, 2, 3, 4. 0 is like breathlessness only on strenuous exercise. So this is present in like healthy individuals. So this is normal. So this is normal. Okay. Then comes grade 1. So they are telling like grade 1 is like breathlessness on walking slightly hill or walking slightly up. Grade MMRC grade 2 is like dyspnea on like patient used to walk slower than the people of same age group and like it can he can stop for breath when walking with on pace of on the same level. Okay, so like they used to walk slower than the people of same age. So this is grade 2. Then comes grade 3. So grade 3 is very simple, like dyspnea on walking 100 meters, very very important, or few minutes. Then comes grade 4, in which like there is dyspnea even on dressing on and undressing, or like patient used to be too breathless to leave the home. Okay, then comes like dyspnea questionnaire, the modified medical research council dyspnea scale, MMRC scale. So this is like uh, this contain a lot of features, not only dyspnea. So first thing is like cough, patient used to cough. If he is having never cough, then we will tell it like we will give him 0 grade. If he has cough all the times, then we will give it 5 grade, 5 numbers. Then comes sputum production. Then like chest tightness is there or not. Then comes like patient is breathlessness on like how much breathlessness he is. Then comes like uh, activities are restricted or not. Then comes like patient is confident leaving the home despite the lung condition, or he is not that confidence. Then come like patient used to sleep properly or not. Then comes like he is having a lot of energy or there is loss of energy. So there are like total 8 criterias, and every criteria can be given from 0 to 5 grade. So like maximum 40 points can be given. So highest points are 40 and lowest are 0. So 0 to 40 is the like grading of this. Like this is like cat assessment. Cat assessment, very very important. Cat assessment, yeah. So now they are telling about the multi-dimensional questionnaire. So they are telling now it has been recognized that COPD impact patients beyond is dyspnea. So there are multiple factors are there, not only dyspnea. For this reason, multi-dimensional questionnaire are recommended, and most comprehensive disease-specific health status questionnaires such as chronic respiratory questionnaire (CRQ) and St. George's Respiratory Questionnaire (SGRQ) are important research tools, but they are too complex to use in the routine practice. So we can't use CRQ and SGRQ in routine practice. So they are telling like shorter comprehensive measures such as COPD assessment test we have already discussed in previous slide. So like that CAT and like COPD control questionnaire like CCQ have been developed and are suitable to use in the clinics. So now we will discuss about the CAT questionnaire and SGRQ, St. George Respiratory Questionnaire, in the next slide. So they are telling what is the CAT questionnaire. So we have already discussed CAT questionnaire. So this is 8 item questionnaire that assess the health status in the patient with COPD. It was developed to applicable worldwide and validated translations are available in all the languages throughout the world. So they are telling the score ranges from 0 to 40 and correlate very closely with the SGRQ and has been extensively documented in the numerous publications. So this is like very standard questionnaire. So CAT questionnaire. And second one is SGRQ, St. George Respiratory Quotient. So SGRQ. Now we will discuss about SGRQ. SGRQ is most widely documented comprehensive. Like this is comprehensive one. This is shorter one. This upper one is shorter, but this is SGRQ is comprehensive measure, and they are telling like score less than 25 are uncommon in diagnosed COPD patients. So they are telling like in patients who used to got diagnosed COPD usually have SGRQ score more than 25. So score more than 25 are very uncommon in healthy persons. So they are like common in COPD patients. Therefore, it is recommended that a symptoms score equivalent to SGRQ score more than 25 should be used as the threshold for consider regular treatment for symptoms including breathlessness, particularly since this correspond to range of severity seen in patient recruited to the trial. So they are telling like equivalent cut point of the CAT is 10. Like SGRQ of 25 is equals to uh, CAT of 10. So CAT score of 10 is equals to SGRQ score of 25. An equivalent MMRC cannot be calculated because that is very simple breathlessness cut point cannot equate the comprehensive symptoms score cut point. So the great majority of patients with SGRQ score of more than 25 usually have more than one of MMRC grading, and they are telling like however patients with MMRC less than one may also have number of other COPD symptoms. For this reason, the use of a comprehensive symptom assessment is recommended. However, because of use of MMRC is widespread, an MMRC grading of more than 2 is still included as a threshold for separating less breathlessness from the more breathlessness. It means like if patient is having MMRC grade more than 2, then we will consider it like SGRQ score of 25 and CAT score of 10. Very, very important. Then comes next slide, which is like what is the gold ABE assessment tool. As we know, initially it was ABCD assessment tool, and now C and D has been replaced by E. Very, very important. So now C and D has been replaced by E. New change. So they are telling we have to first we have to spirometrically confirm the diagnosis, then we should assess the airflow obstruction, and according to that we have to check assessment of symptoms and risk of exacerbation. So they are telling like spirometrically post bronchodilator FEV1 upon FVC should be less than 0.7. Then comes assessment of airflow obstruction by gold criteria. So gold grading, according to gold grading, they are telling like gold one we know more than 80%. Then comes gold two, FE1 of percentage predicted should be like 50 to 79, then 30 to 49, then less than 30. Then comes assessment of symptoms and risk of exacerbation. So they are telling if like first of all we have to check what are the number of exacerbation, and then we have to check like MMRC or CAT grading. So they are telling like if MMRC and CAT grading, MMRC is grading is less than 1 or equals to 1, like it is from 0 to 1, and CAT scoring is less than 10, and exacerbation is like 0 to 1 observation is there, then we'll tell it like this is category 1. If more than two observations are there, or like there is history of hospitalization is there, then we will simply tell it uh, score of E. We will tell it like this is E category. So in E, for qualification of E category, there is no need to check MMRC grading or CAT scoring. Like it could be anything, but there should be history of moderate exacerbation of more than two, and or equals to 2, and like history of hospitalization should be there for definition of grading. But for differentiating A and B, MMRC grading, like there should be a history of exacerbation of 0 to 1, and like MMRC grading, if it is like between 0 to 1 and CAT scoring is less than 10, then it will be category A. If MMRC is grading is like equals to or more than 2 and CAT scoring is more than 10, then we will call it B, uh, category B. So simply there are three uh, categories. Okay, guys, thank you so much. Good night.